Dear Professor Caprini， 尊敬的崔教授，尊敬的医院长，尊敬的各位专家，各位同道，晚上好。很高兴今天跟各位相聚在这里，参加安全地带医院 VTE 管理中国行 Caprini 对话中国的活动。那大家知道我们现在处在一个比较严峻的时期啊，新冠肺炎的这个疫情期，在中国在党中央的领导下，我们已经取得了初步阶段的决定性的胜利，但是事情还远远没有结束啊，还有大量的工作要做。现在输入性的病例成为一个主要的来源。今天这个习近平主席和特朗普总统通了电话，讲到国际防控合作的问题。现在美国的病例爆发这个爆发期，所以我们也对 Professor Caprini 表示一个慰问，相信啊，在我们两国的专家或者两国人民共同努力下，包括全世界的人民共同努力下，一定能够战胜这个病毒，战胜了新冠肺炎啊。那么这里我还要表示敬意的就是，我们今天晚上有8个学科的专家共同聚在一起讨论，在这个形势下的 VTE 的管理的问题。那么大家也都知道啊，卫生部国家卫健委非常重视这项工作，把 VTE 的院内防治工作提升到一个很高的高度啊。所以说我们在这里呢，我们各个学科的这个专家，特别我要表示敬意的就是我们呼吸科的各位专家们，因为这一次的疫情，我们呼吸科的专家们不是赶赴武汉、湖北第一线，就是到各个医院去会诊，并且在自己的医院做了大量的工作啊。那么呼吸科的医生在这次疫情中总是站在第一线，我们要对他们表示一个崇高的敬意。
好，各位，方才呢，我们那个王世明主席呀，就我们这次活动的整个背景呢，给大家呢做了一个介绍。的确呢，在这一段时间呢，来自全球的这种疫情呢是非常严峻的，特别是在美国呢，现在这个疫情呢是更加的这个看到曲线的这个在逐步的走高，所以呢，我们大部分的人呢，我们两地呢现在都在这个居家隔离这个可能是有我们更多的时间呢，能够在网上来进行探讨我们这些学术的问题。也正如方才王主席说的这样，我们这个在这个疫情的这些病人，特别是得了冠状这病毒这些病人啊，那么他们面临着一个非常重的一个非常严重的并发症，那就是我们的 VTE。那么这个 VTE 呢，涉及到很多的学科，比如说我们的骨科、我们的呼吸科、重症科，还有血管外科、妇产科、肿瘤科等涉及到很多的专业。我们今天呢，就是针对这些VTE 风险非常高的专业呢，我们一共呢请到了14位专家，特别是我们今天呢请到了这个美国的这个 Caprini 教授，一会儿呢我们要连线 Caprini 教授呢，来就血栓在疫情期间，特别冠状病人的血栓呢，它的这个一些学术问题呢，我们通过我们大陆和我们这个叫中国和美国两方面呢，来进行一个经验的这一个互动和共享。下面呢就是我们要进行会议的这个讨论。我们的讨论的这个主要呢围绕着这3个方面。第一个就是 VTE 呢对外科的经验大家呢就博采众长，各自呢来介绍我们的经验。第二个呢就是肿瘤 VTE 呢有些哪些特殊性，也就是外科方面我们要讨论，肿瘤方面我们要讨论，还有一个就是我们把中国的这个目前的这个在疫情期间这一个特殊环境下或者特殊背景下，我们这个 VTE 呢它是怎么防控的，应该做到什么，这个3个方面呢我们呢来连线互相来讨论。下面呢由我来介绍一下我们呢今天的连线的各位专家。首先呢是我们 Caprini 教授。我们知道 Caprini 教授呢是我们美国芝加哥大学的这个高级的教育学家。我们现在用的这个VTE 这个筛查的这个风险的量表呢， 就是由我们这个Caprini教授呢，由他呢当年呢来制定的。那么目前呢，现在已经在这个据说在这个300多万这个患者中呢，已经得到了验证。而Caprini呢教授本身呢，他也发表了很多的文章，我们检索了一下，大概是有130多篇文章呢，在全球呢这个许多国家呢，大家都在学习他这个量表应用的一些经验和他的这个一些效果。这是我们尊敬的这个外宾美国的教授Caprini教授。那么我们今天呢，还有来自全国的这些专家们首先是我们鼓楼医院的蒋清教授，蒋院长，他是我们骨科呢做血栓做的，我认为做的是最好的专家了。特别那个蒋教授呢，他不但在临床方面做了很多的工作，而且呢在研究方面呢也做了大量。另外呢，就是来自这个上海的复旦大学的中山医院的史振宇教授这个也是我们大家都相当熟知的。还有来自我们四川大学华西医院的尹如铁教授，那么另外还有这个中山大学附属肿瘤医院的陈功教授，现在还有呢来自北京的首都医科大学附属北京朝阳医院的李辉教授，还有天津医科大学总医院的门建龙教授，特别还有我们来自中日友好医院的翟振国教授。翟振国教授呢，给大家介绍一下，他是我们这个国家呼吸呼吸重症的这个临床研究中心的，应该是办公室主任吧，是从我们那个王晨院士做了大量的这个血栓方面的研究。我们现在中国的血栓那个指南的红本，应该分了这个一个很大的一个册子，这个红本呢，就是我们翟振国教授呢，带领这个团队，在王晨院士的这个领导下，当然这个我们也参加了这个工作，现在形成了非常重要的一个指南这个。另外呢，还有就是武汉大学中南医院的这个彭正宇教授，还有这个也是我的母校哈尔滨医科大学附属第2医院的陈红老师。那么还有来自四川乐山人民医院的易群教授，易群教授呢也是我们非常这个熟悉的，在很多的这个指南在撰写方面，易教授呢都参与了，这也是我们老朋友了今天呢，我们为我们这个两地进行这个翻译的2位重要的这个嘉宾，一个是来自我们解放军总院的血管外科的贾清教授，那他们这个平时都是做了很多的同传的工作。另外呢，就是来自首都医科大学的附属北京朝阳医院的曲红教授，2位将为我们实时呢做连线的翻译。今天他们可能很辛苦，对他们2位呢也表示个感谢。接下来呢，我们就邀请Caprini教授来抛砖引玉，首先来给我们讲一讲他在 VTE 预防方面，特别是在疫情这个当下，那么有关 VTE 呢应该如何去做，来谈谈他的观点。我们有请Caprini教授。
First, we invite Professor Caprini to give us a brief introduction on the guideline of the VTE prevention and treatment. Please, Professor Caprini.
Hello. It is a great honor to be asked to present these data to the Chinese physicians. Researchers in China have done a tremendous amount of excellent work in forwarding the cause of individual risk assessment, including both the Caprini score and also enhanced versions and other tools to identify as correctly as possible the risk of each individual patient. Here are my disclosures. They're all educational in nature. And I would like to begin by discussing the elements in a Caprini score. First of all, a complete history and physical examination using risk assessment to determine any factors that might influence the outcome of a surgical procedure or hospital stay is the key to preventing venous thromboembolism deaths. Each risk factor has a varying ability or strength to result in a VTE event. Here we can see as the score goes up, it's based on the risk strength of an individual factor. Not only that, but the VTE rate increases according to the number of risk factors present. So the Caprini score elements are a combination of the number of risk factors and their relative strengths to give an overall score. And here we see those scores in representative general surgical and plastic surgical populations. In addition to that, there's a nonlinear increase in clinical VTE rates occurring with these scores. As you can see, in otolaryngology, the rate is very low, but all of a sudden when you get over 8, it jumps to 18%. That was also noticed in the plastic surgery population, where it was 11%. You'll notice that in intensive care, it's a little more regular or linear in its increase. I'd like to go back and take a look at history. You know, if we don't know history, then we have to try to repeat it. And Dr. Maxwell Borrow was a very, very brilliant surgeon who was chief of surgery and vascular surgery at the Somerset Medical Center, which was affiliated with Seton Hall. And he did some landmark work where he studied patients having surgery, and he evaluated their endpoints using fibrinogen scanning confirmed with venography, which is the utmost in detection techniques. We don't use it so much today, but in those days it defined the true incidence of venous thrombosis. And he took a look at a number of risk factors, and the importance of his contributions were that he showed that one risk factor can have different strengths, as we talked about. Look at length of surgery. As it goes up, the strength goes up, and age, the same thing, the strength goes up. One of the most important observations that Maxwell Borrow made, and this was in 1981, 66% of patients with a past history of a blood clot suffered a recurrent thrombosis when they had an operation, unless they had prophylaxis. Now, despite all of the years that have passed since then, the National Surgical Quality Improvement Database of the American College of Surgeons is a fabulous database that now has over 5 million patients in it. Unfortunately, there still isn't a module which shows which of those, to track which of those patients had a DVT or a history of DVT, and also what prophylactic measures they had employed. So we're hoping that in the future, the American College of Surgeons will add this module, because it would be a tremendous improvement in the NSQIP database. As of right now, I would say that it's not really very easy to do retrospective chart studies looking at VTE incidence using the NSQIP database because of the shortcomings in the data collection panel. Now, the Caprini score was first dreamed up actually in the early 80s, and as of the present time, the score has been validated in about 5 million patients, including more than 150 publications worldwide. And this includes some very important publications from China, as well as other countries in both Asia and around the world. It's a comprehensive tool, including a statistical calculation of the power of individual risk factors, combined with a number of risk factors, resulting in a simple score. The score has been shown in these studies to increase in a non-linear fashion, parallel with increasing VTE rates, as we previously discussed. The largest study so far scored 2,795,024 patients. And this was in surgery. This was a big study in 4 hospitals in Hanoi and Vietnam. And it showed, as did many other studies, the escalating risk of venous thromboembolism with increasing scores. There are a few studies that have failed to show the correlation of the Caprini score with the incidence of VTE. Most commonly, this failure to be successful was related either to improper data collection or data analysis, or retrospective studies where the data wasn't really fully known, which questions were asked. And then finally, there are a few papers that point out that there are some additional things that need to be considered besides the Caprini score in determining the risk of the patient. And of course, this is always true. There's always additional things that come up with time that are important to add to, but this does not invalidate the basic concept of this score. The score captures all 40 elements, and it's a time-consuming process. But we have, due to some bright people working with me, facilitated having the patient complete a preliminary patient-friendly form in advance of elective surgery, ideally with the help of family members. Did you ever go to the doctor without your spouse, and when you get back and you talk to your spouse will ask you, well, did you ask the doctor this? No. Did you ask the doctor that? No. Did you talk to the doctor? Of course I talked to the doctor. So what we know is that when we're in the doctor's office, what are we worried about? We're worried about the surgical procedure that's coming up. How long am I going to be out of work? How painful will it be? Will I be back to normal? Will you have a bad day and will I have a bad outcome? Those are the things that are not on your mind, not things about your history, and especially family history. So that's why it's important to do this ahead of time with family members. And then when you do this patient-friendly form, you can bring it in, and then the person responsible for doing the initial history and physical examination for the patient should be the one that checks over this form, corrects any errors, and finalizes the document. We now have this patient-friendly form in a variety of versions. There's at least 7 or 8 translations of the patient-friendly form, and probably 2 or 3 times that number of the original Caprini form throughout the world. We're not exactly sure how many that is. The initial form asks a series of questions, and you can see from looking at these slides, they're divided into 1-point questions, 2-point questions, 3-point questions, and then 5-point questions. And then for the healthcare provider, then there's some additional points for some more recent risk factors that have been shown to be important in calculating the total risk score. And then finally, based on that, a concluding score. And this is the patient statistics for the validation between a patient-completed form and a physician-completed form. And they have very good agreement. We do know that patients often fail to answer the family history question correctly. You have to remember that there is good data in the literature to show that all 3 degrees of family relatives are important and powerful predictors of a DVT in a patient. Patients often don't understand how to calculate their BMIs. They often overlook pitting edema without finger pressure by the examiner. Same holds true for varicose veins. And then the history of obstetrical complications is not fully understood. This is a really important area that really needs emphasis. Women that suffer repeated unplanned abortions, or a stillborn, or severe toxemia of pregnancy, or placental insufficiency, or growth retardation of the infant. All of these things are clinical signs that the patient may be harboring an actual antibody to their own clotting proteins, known as antiphospholipid antibody syndrome. And there's a laboratory component, which is the antiphospholipid antibody, or beta-2 glycoprotein, and there is a clinical component, which are those obstetrical complications that I discussed already. This defect can carry through a person's life. So long after the patient, let's say the woman is not having babies anymore, but is in her 60s or 70s and needs a hip replacement or a colon resection, that gene may still be there, that defect. So you have to test for that defect. And who do you test? You test those people that have that history. So that's a very important historical question. Almost all the risk assessment documents throughout the world that have been developed omit this very important risk factor. So to conclude, the healthcare provider reviews the patient form and goes over these specifics, and then a final admission document is calculated. Notice I said admission score. That's just the beginning. Here we can see the difference between bulging varicose veins and spider veins. That's an important consideration. And here are some important considerations regarding leg swelling and/or foot swelling. Leg swelling may indicate venous insufficiency or other cause, but lymphedema may be predicted when the foot is also swollen. Now be very, very careful. A surgical procedure considered to be minor from the surgical standpoint, like a vein ablation or a simple appendectomy, may be a major surgical or thrombotic risk according to what we know about the thrombosis standpoint. And what I mean by all of that is that you can take a simple operation and in somebody that has a past history of thrombosis, a family history of thrombosis, or other risk factors, cancer perhaps. And so even though it's a low-risk procedure, it's a very, very high risk for the patient because of the so-called patient's baggage or the factors that the patient carries with them forever, wherever they go. Now, in about 1850, Professor Rudolf Virchow, who was a famous pathologist, came up with the 3 factors which he thought were important in the creation of a venous thromboembolism: venous stasis or slow blood flow, vessel wall injury, or hypercoagulability of the blood. When all 3 factors are present, as shown in this diagram, the likelihood of thrombosis is very high. Now let's take a look at what happens during a major anesthesia. First of all, the patient is lying on the operating room table, and in order to intubate the patient, a muscle relaxant is given, and that causes the muscles in the calf to relax. So all muscle tone is lost. As a result of that, the veins can actually enlarge and become over-distended, and as they do, cracks can form. Philip Coleridge Smith, many years ago, showed a very interesting series of experiments where patients had duplex scan examination of their leg veins before and after the administration of a relaxation, the paralyzing agent to relax the calf muscles. And when those calf muscles relaxed, it was fascinating to see up to a 3 times dilatation of the veins occurred. In addition to that, hypercoagulability can develop in these veins that are overstretched. There are cracks in the wall. The blood is sitting there, but the metabolites from the muscles are still pouring into those veins because the muscles are still alive. But now those metabolites, because they are not flushed out of the veins, can produce or increase hypercoagulability. In addition to that, the stress of the surgery. Imagine if somebody sliced a knife across your abdomen awake. Tremendous stress that would produce. Well, that stress is still there, although you're anesthetized and you have pain medicine. And so that stress can also trigger an increase in coagulability. In addition to that, why is the patient having the operation? Maybe they have infection. Maybe they have tumor. And in those cases, that also increases the hypercoagulability. And then as time goes on, the length of time of the surgery is important because that intensifies all these effects. And this is why it's so very, very important to use pneumatic compression during the operative procedure as much as possible in order to minimize these effects. Now I'd like to show you a 1 million power micrograph, some very elegant experiments done with Dr. Anthony Camerata, who's a famous vascular specialist, and his associates. And what this shows is as the blood flow slows, the vein expands, overfilling the vein with blood, and the endothelium cracks as this vein gets bigger. Here is the endothelium, and you can see clearly here the cracks where that's occurred, exposing subendothelial collagen. And when that happens in this area, now this is a blown up area of a crack, and you can see the clots forming as a result of the contact of this hypercoagulable blood with the exposed collagen. Another thing happens when venous blood flow slows, and it's depicted in this cartoon from Andrew Nicolaides. Notice how all of a sudden it got dark, because as the blood flow slows, the the white cells change themselves into adhesion molecules. And these adhesion molecules actually land on the surface of the endothelium, where they finally come to rest. And when that happens, they extrude inflammatory granules and inflammatory cytokines, which cause a disruption in the wall of the capillary and render it useless. In addition to that, then additional white cells come along, changing into adhesion molecules. And the end result is that that capillary is irreversibly damaged. And if we take a look here, this is an animal experiment where it's actually shown there's an adhesion molecule, here's the endothelial wall, and here is that adhesion molecule beginning to penetrate the capillary wall. Another important phenomenon on the operating room table, notice that it's very common to put a pillow under the knees. Now, why is that? The reason for that is because of popliteal entrapment. And here we see a video of a slightly bent knee, and as the knee is extended, the vein, which is on the top here, closes because the gastrocnemius muscle can force that to happen in a fully extended position. And that's why soldiers and guards, when they're standing at attention, are urged not to lock their knees because that could slow blood flow out of their leg and they could actually faint. So in summary for this section about surgery, minor operations may be major from the thrombosis standpoint. Those procedures requiring over 45 minutes of general or regional anesthesia are considered major from the thrombosis standpoint. The longer the procedure, the greater the risk. Pneumatic compression device. It's important for everyone to understand that the total venous thromboembolic risk for a patient consists of the inherent risk of the surgical procedure plus the patient's baggage. This baggage is the collection of individual risk factors that are peculiar to this particular patient: cancer, infection, those past obstetrical problems, and so forth. It's very important to keep this in mind. You can't just go by the surgical procedure, and you can't just go by the the risk factors. You have to put it all together. Now let's talk about some of those individual risk factors. How about ambulation, immobility? This is a very frequently misconstrued and misinterpreted risk factor. Immobilization, patients that are confined to bed for less than 72 hours, we classify them as, give them 1 point. And this includes them being up in the chair and going to the bathroom, because there is data in the literature, and we're going to cover that in a minute, to show that if you can't walk 32 feet at one time, then you're immobile. And your incidence of DVT is twice that if you could walk 32 feet. Now, if you're confined to bed for over 72 hours, that increases the risk, so that's 2 points instead of 1. In addition, you have to add 2 more points to any patient who has a device on their leg that prevents a normal contraction of the calf muscles and the foot muscle pump. Plaster casts, leg braces, posterior molds, walking boot, crutches with a toe touch. Immobility is a well-known risk factor for venous thromboembolism, and as we said, includes those that are unable to walk 30 feet at one time. And in this study that was reported by Amin, which was a sub-study from a large study done around the world, the rate of VTE in patients without prophylaxis was 19.7% compared to 10.6% if the patient could walk 30 feet. Patients that were using a cane or a walker for stability are not considered as having restricted mobility if they're using their calf muscles for ambulation in both legs. If a patient has one leg that's non-weight bearing, then they're immobile, even though they can walk 30 feet. Sitting up in a chair or walking a short distance to the bathroom does not qualify as ambulation. If a person has a leg cast, boot, or brace that inhibits the normal calf muscle action in one leg, as previously mentioned, they're still considered immobile. As a matter of fact, there's good data to show that a non-weight bearing leg has the same blood flow as a person sitting down. So it is of no good to be walking with the other leg for the affected leg. One of the most common misconceptions is that when patients are ambulatory, there is no need to continue their anticoagulant prophylaxis. Oftentimes, you'll hear the nurses in the hospital telling the patients, if you just get up and walk around, then I don't have to give you this shot because it's painful. And that's absolutely not true. Typically, patients have had surgery or a serious illness that previously confined them to bed. Normal walking does nothing to reduce the risks associated with the other risk factors that the patient has now that they're walking. They still had cancer, infection, history of thrombosis, congestive heart failure, inflammatory bowel disease, to name a few. So many hospital guidelines suggest that anticoagulant prophylaxis can be stopped when the patient is ambulatory, and that's totally incorrect. These criteria for stopping anticoagulation are wrong. Prophylaxis needs to be continued for those with risk factors for the time period that has been shown in clinical trials to be effective. 165 trials in 43,000 patients over a 30-year period document that 7 to 10 days of prophylaxis is the proper duration of prophylaxis to prevent blood clots. Patients at very high risk may need even longer periods of prophylaxis, 30 days in some cases or more. And the concept of giving one dose of anticoagulation within 24 hours of surgery has shown to be ineffective prophylaxis. All it does is increase complications. And short 1 to 2 days of prophylaxis during hospitalization have been shown to be ineffective for thrombosis prevention. It's astonishing to me that the brilliant investigators that have come up with all of the guidelines have seemed to commonly refer to the fact that prophylaxis should be considered during hospitalization and intimate that when the patient goes home, that prophylaxis can be discontinued. Now, why has that been going on? Well, first of all, we know in the surgical populations, they need a full course of prophylaxis. And now that you're sending them home sooner, you still need to give them a full course of prophylaxis. But in the medical patients, it's more complicated, I realize. And that's because prolonged prophylaxis with anticoagulation in medical patients often increases the bleeding complications as much as it lowers the DVT rate. So there is a controversy about when and where to do that. But those guidelines were written and they did not include a specific risk assessment for the patient so that only those highest risk patients got the prophylaxis. So that's an area that's in flux, but most important to make sure that you give prophylaxis for the period of the time that the patient remains at risk. Now let's talk about chart review. Chart review is a notoriously bad way to estimate risk. And Christopher Panucci, who's a brilliant investigator, he's a plastic surgeon who's done a number of important research investigations regarding risk assessment, not only for the Caprini score, but also risk assessment in general and the use of anticoagulation and using tests to monitor low molecular weight heparin to look for adequate levels and so forth. Many important contributions, and I encourage you to look up his name and look at some of those important contributions. One of those he presented at the American Venous Forum and subsequently published was a comparison of chart review to face-to-face analysis. And just two quick excerpts from that. In chart review, a history of a stillborn infant, recurrent spontaneous abortion, premature birth with toxemia, or growth restricted infant was only noted in 0.6%, whereas with live interrogation it was 13.9%, over 20-fold increase or more. Same thing with family history of thrombosis. Family history of thrombosis was increased by a relative risk of tripled from 5.2 to 17% when face-to-face examination. Remember we talked about the person doing the history and physical as completing the final score, but that's the final admitting score. As a person goes through their hospitalization, things can develop, such as reoperation, infection. Central lines may have to be inserted because of poor IV access. Cancer unsuspected on admission may be diagnosed during the stay. So the updated score often will result in a change in thrombosis prophylaxis, including post-discharge anticoagulant prophylaxis. Now, I've written a blog recently to illustrate this point using an imaginary patient. The patient is having a laparoscopic cholecystectomy, is over the age of 40 with a BMI of 30. So that gives this patient a score of 4. Age over 40, BMI of 30, and a laparoscopic cholecystectomy which lasted longer than 1 hour. Now, post-operatively, unfortunately, the day after surgery went fine, but the next day the patient leaked from the cystic duct stump and developed a big biliary abscess. The patient had to undergo an endoscopic retrograde cholangiopancreatography, ERCP, with the placement of a stent. The patient had to undergo an interventional radiology procedure to drain the abscess. The patient didn't have good IV access, so a central line had to be inserted. So now we have, in addition to the original 4, we have 1 for the ERCP, 1 for the percutaneous drainage, 1 for the bile leak with infection, 2 for the central line being inserted. Then, because of all of those interventions and because of the pain associated with the peritonitis of bile in the peritoneum, the patient's in bed for the next 3 days. So the patient is now ambulatory. That's another 2 points. Now the score is over 10. Well, would anyone be surprised that on the 7th day this patient dies of a fatal pulmonary embolism? Because her score was really very high and she required prophylaxis, whereas the initial score didn't indicate that. So this little imaginary case is to emphasize the dynamic nature of this instrument. And the patient needs to have scoring done as events occur during the hospitalization, and then a final score at discharge to make sure that the recommendations are not to include post-discharge prophylaxis. One of the key features of the Caprini score is the fact that over 50% of the patients have low scores and they don't need prophylaxis. And if you give prophylaxis to low-risk patients, there's abundant evidence in the literature that that doesn't further lower the DVT rate, it just increases the bleeding complications. So you don't want to give patients with low scores anticoagulation. Most patients who have a score between 5 and 8 deserve prophylaxis, and the appropriate courses we know over the past 40 years is 7 to 10 days. Those patients who are at very high risk with high Caprini scores may need extended anticoagulation up to 30 days. Now, those are the guidelines. Unfortunately, those guidelines, those evidence-based guidelines, and the execution of those guidelines are disconnected, just like this poor fellow who's become disconnected from his motorcycle. So now, how do we go about creating or eliminating this disconnect? The first step is to have a physician audit their individual practice and analyze patients over 90 days in a consecutive group of them for their incidence of blood clots, and then calculate the rate of venous thromboembolism in those patients that had the recommendations followed versus those that didn't have the recommendations followed. At this point, we're making no attempt to change the doctor's behavior. If they didn't feel that they needed to give prophylaxis, they didn't give it. But now you have a 90-day audit to see how accurate their decision was. And compare the rate in the 90 days to those people who did and didn't get appropriate prophylaxis. And then after that, the chairman of the department can schedule a formal meeting with the physician to discuss improving their compliance by following the recommended guidelines more of the time, and then go ahead and see if that changes the incidence. I really like that approach rather than coming down hard on the patients, on the physicians, and tell them you will complete the follow the guidelines before you can sign your order. So I just think that's a softer way to do it. But we have to have, if you don't have mandatory compliance in some fashion, then the lasting effect on lowering the VTE rate using the risk assessment will not occur. And don't forget, one would never, ever, ever take the decision out of the patient's hand, the doctor's hands. They can always opt out if they feel there are valid clinical concerns. Now, later they may have to justify those clinical concerns, but they certainly have the ability and the power to opt out. We never want to take that away. I'd like now to present to you from the United States what I consider the benchmark program for preventing venous thromboembolism. And this is a program from Boston University by Cassidy and Professor McEnany and their associates that called for a mandatory selection of prophylaxis along with adequate ambulation, and then adjusting the prophylaxis according to the score. And here we see the results. Now, at the time when this was done, you will see that those patients who were up to 1, 2, 3, and 4 risk factors, they also got low molecular weight heparin, but that's because there was an initiative in the United States called the Surgical Collaborative Improvement Program, which called for giving a dose of anticoagulation within 24 hours of admission to surgical patients. That policy has been since found to be invalid because it didn't lower the DVT incidence. You'll notice that in the Boston study, there was 100% agreement with those recommendations in the lower risk patients. When the patient hit 5 risk factors, from 5 to 8 risk factors, they had compression therapy during the hospitalization, and then no matter even if the hospitalization was short, they got 7 days of low molecular weight heparin injections. 89% of people complied with that. Then 30 days of low molecular weight heparin were recommended for those with a score of over 9. Now, low molecular weight heparin injections are not only painful, but they're expensive in the United States, and there's something called the Medicare donut hole, which meant that some older patients might have had to pay up to $1,500 US to have that 30 days of prophylaxis. So how did they do this? Was this some fancy hospital where the patients were very affluent? No, this was an indigent hospital, but the hospital administration made a deal with the drug companies and the local insurance plans to provide the prophylaxis to everybody that needed it, regardless of their ability to pay. And as you can see, 3/4 of the patient did follow this program. What were the results? Here we see what happened. You can see that the incidence of thrombosis, which was very high before the program started, and ICOF is a program of getting the patients up, ambulating them, having them sit up, cough frequently, and so forth. That helped the DVT rate a little bit. But the DVT rate really went down when the patients had this program instituted. And here we see when the program was instituted and how it came down after that to a very low level of 0.1%. And again, it's very important to emphasize that there is a big difference between low scores where the risk of bleeding outweighs the use of anticoagulant prophylaxis and it shouldn't be used, to high scores which justify anticoagulant prophylaxis, which if omitted may result in fatal pulmonary emboli. And in order to further illustrate that point, let us take a look at this series of trials. It's 33 trials and 33,000 patients. And what it shows is the incidence of bleeding complications that weren't trivial. There were no deaths. But as you can see, wound hematoma, discontinuing prophylaxis, and even reoperation had a certain incidence. And let's take a look at low molecular weight heparin, shown in this yellowish band. 4% incidence of wound hematomas. Well, if the incidence of DVT is 1.2%, then it's not worth giving them anticoagulation to get 4% hematomas or 3.4%, where the prophylaxis had to be discontinued, because now if it's discontinued because of a bleeding complication, then the risk can go way up. So it's very important to balance the risk of thrombosis against the risk of bleeding. On the other hand, postoperative death from bleeding using prophylactic doses of anticoagulants is very, very rare. But withholding anticoagulation in surgical patients at risk is associated with an increased incidence of fatal VTE, which is not rare. And here is a study from the 4,000 patient meta-analysis, multi-center study in England showing that a low dose unfractionated heparin saves 7 lives for every 1,000 operated patients. And then a subsequent analysis by Collins, and this is another 13,000 patients using the same criteria as the multi-center trial, that the incidence of prophylaxis, when it's continued for 1 week, you can see that the incidence of deaths from PE is reduced from 0.9% to 0.3%, and the fatal bleeds are no different, 0.1% in either group. So that the administration of unfractionated heparin is associated with a 66% relative risk reduction in fatalities when given for 1 week. Now let's talk about another study, which is a very pivotal study, and you should all keep this in mind when you're deciding whether or not to protect your patients. And that is the incidence of venous thromboembolism was studied using the endpoint of autopsy adjudicated fatal pulmonary emboli. And it was a study done by a drug company who wanted to show that their drug was as good or better than unfractionated heparin. And as you can see from this slide, there were 23,000 patients that were given prophylaxis from 5 to 20 days. And the fatal PE incidence at autopsy was no different between those that got low molecular weight heparin, 0.1%, to those that got unfractionated heparin. Same holds true with fatal PEs, non-fatal PEs. So anticoagulant prophylaxis reduces the risk of death to 0.1%, and no deaths from anticoagulant bleeding were noticed. So if you give the proper course of therapy for a week, you can reduce the death rate to 0.1%, and the pulmonary embolism rate, as you can see, is extremely low. Now let's take a look at an important study. Again, we're back to Dr. Christopher Panucci. And he did a meta-analysis where he took a look at a large number of surgical patients and whether or not they got prophylaxis. And you can see here that if they didn't get prophylaxis, that the incidence of DVT was 10.7%. And you will also see that the incidence of DVT in the lower risk group was very low. So it's very important to make sure that your patient has a risk assessment. And using this score, 50 to 60% of all patients can be spared anticoagulation. Take a look at this line. That was 22,000 of the patients. Now, if you extrapolate this to outpatients, one of my favorite discussions about misconceptions is that the location of the procedure doesn't necessarily determine the overall risk of the patient. If the patient is having an outpatient procedure but has a lot of baggage, they may have a very high incidence of venous thrombosis. And if we take a look here at those patients in this study that had 8 or over 8 risk factors, then you can see that not providing prophylaxis to them, if they were outpatients, would have resulted in a number of deaths. So until this theory is disproven, it may be wise to use a prophylaxis in these patients with high scores, 7, 8, and above, because death from anticoagulant prophylaxis is rare, but death from PE is common, especially in high-risk patients. Now let's take a look at the largest study to date using the Caprini score, which comes from Vietnam. And it took a look at 2,795,024 surgical patients with proven VTE rates by appropriate imaging at 90 days. And you can see the escalation in risk and how it goes up depending on the score. Now, it's very important to understand that this study shows exactly the same type of scale as seen in the other studies. And that overlap in the scale gives it great validity. And what an amazing accomplishment this study was. Now, another study that comes from Boston University evaluated over 300 lung and esophageal cancer resections who received in-hospital prophylaxis with unfractionated heparin 3 times daily and pneumatic compression. This was the standard procedure at the time. And the incidence of VTE was compared to 64 patients who were subsequently studied in the post-intervention group, where these patients had extended prophylaxis based on their Caprini scores. A total of 22 VTE events occurred within 60 postoperative days in the pre-intervention group, and there was a 58% reduction in postoperative VTE incidence from 7% down to 3% in the post-intervention cohort. Although this was non-significant, it demonstrated a significant lowering. Now, no VTE events occurred in lung and esophageal cancer resection patients between August of 2014 and September of 2016 using this protocol. And this impressive absence of VTE events in these high-risk patients for 2 years needs to be tested in a larger cohort. Now let's take a look at a fascinating study from China. And as you can see, these were patients undergoing lung resections without preoperative venous thromboembolism prophylaxis. And there were very few low-risk patients, and they didn't have any incidence of VTE. But as the score went up, the incidence of VTE rose dramatically and was 40% for those with a score of 9 and above, compared to 0% for those with a score of 1, 2, or 3. Now let's take a look at medical patients. And here's a study from the University of Michigan showing how the incidence of VTE went up in their patients that were a mixed population receiving and non-receiving prophylaxis. Now, the Chinese have published important studies, and in fact, the most important studies to date regarding the Caprini score, and I would remind you that they are all summarized in the Disease a Month publication that's listed here in this slide. If we talk about orthopedists, the clinical usefulness of clinical predictors of preoperative screening for deep vein thrombosis in hip patients. This is a study of 92 hip fracture patients, and in these patients, the DVT incidence was 16.3% preoperatively. And the authors recommended that in patients with a Caprini score of over 12, they should be screened with a Doppler preoperatively because of their incidence of venous thrombosis. This study in hip fracture patients showed that the incidence of preoperative DVT was 16.3%. And based on that, the authors recommended that patients with a Caprini score of equal to or greater than 12 should be screened with a Doppler preoperatively. Now, this is a very important study that was done in New York involving 1,000 patients having total joint replacement over a 15-month period. And these patients were treated according to a department-wide protocol. This department protocol considered patients to be high risk if they had a VTE within the prior year, morbid obesity of a BMI of over 40, with additional comorbidities, active malignancy, bilateral stage total joint replacement, and inherited or acquired thrombophilia. Low-risk patients using the department protocol were treated with postoperatively with aspirin. So that meant all the rest that didn't have one of those criteria. High-risk patients were treated according to the department's guidelines, and they received conventional anticoagulation with a direct oral anticoagulant postoperatively. DVT was seen in one of 279 patients, whereas with their classification, the low-risk patients, there were seen 7 VTE events. So the authors concluded that their risk classification did not identify high and low-risk patients. Now, retrospective Caprini scores were calculated by a team at the end of the study and compared to the results of the department protocol. Caprini scores of 10 plus, there were 7 VTE events, and less than 10, 1 VTE event. And standard anticoagulation, therefore, was advised for those with a score of over 10, whereas aspirin was recommended for a score of less than 10. Based on these data, these were the recommendations. Now, failure to account for a family history of venous thromboembolism, including known thrombophilia markers, is a potential fatal flaw in the risk assessment process. This is a really important study in 183,000 individuals from Scandinavia. And what this clearly shows is that the risk of venous thrombosis is not only high in first-degree relatives, but also second- and third-degree relatives and non-biologic relatives. The genetic component of family clustering of VTE is strong, and family history is potentially useful for clinical VTE assessment, even in second- and third-degree relatives, as seen on this slide. It's even shown to be increased for people that are living together, and of course that may be related to common eating habits and smoking habits and so on and so forth. The value of family history as a risk indicator for venous thrombosis has also been analyzed in some very important studies, and it's been shown that the relative risk of thrombosis increased with the number of risk factors identified. And if one had a combination of a genetic and acquired risk factor, a 60-fold higher risk was seen than for those with no known risk factors and a negative family history. So a positive family history plus additional risk factors is very important. Also, the study showed that a positive family history increased the risk of venous thrombosis more than 2-fold, regardless of the risk factors precipitating the thrombosis. So the American Society of Hematology has just published 2019 guidelines for the management of venous thromboembolism. And this appears to be a scholarly exercise, not useful for critical individual risk assessment and selection of prophylaxis. The disclaimer for almost all the recommendations is as follows: a conditional recommendation based on a very low certainty in the evidence of effects. I don't know really what that means. The Caprini score was mentioned twice, and none of the 150 studies and nearly 5 million patients in 20 languages is mentioned. This was an apparent movement away from individual risk assessment, so it's going to be subject to a lot of additional analysis and discussion as we go forward. So finally, in conclusion, never kill a friend, never treat a stranger. This saying comes to me from a very brilliant dentist from Maine who is a dear friend of mine, and what he meant by that was performing a thorough history and physical, gives you knowledge about your patient, so they're just as if they were a good friend. And of course, you would never do anything to hurt a good friend. So I'd like to thank you all for listening to this presentation, and I hope you all have a wonderful day, and hope we have an end to this crisis with the virus. Today we're facing one of the most serious challenges in medicine of our time, and this relates to the sudden appearance and proliferation of the coronavirus disease. I would like to explore with you today about coronavirus and thrombosis. What do we know so far? Here is a study that was reported recently talking about abnormal coagulation parameters and how they're associated with a poor prognosis in patients with novel coronavirus pneumonia. In this particular study, 183 patients from Wuhan, China, were studied with their coagulation tests, and the mortality was 11.5% in this population. And in those patients that had coagulation test abnormalities, elevated D-dimer, elevated fibrin degradation products, prolonged prothrombin times, and prolonged thromboplastin times, those were all indicators of mortality. And the levels in patients that died were much different than the patients who survived. In addition, disseminated intravascular coagulation was seen in 15 of the patients, which was 71% of those that had died, compared to only one of the survivors. And you know, this is a very serious disorder, and sepsis triggers this. And that sepsis can result from a viral infection and lead to activating clotting, so there's an increased thrombin level in the circulation, as well as increased fibrinolysis. And the authors of this study concluded that the D-dimer and fibrin degradation product values may have had prognostic significance and also be important therapeutic targets. What happens with disseminated intravascular coagulation is that as a result of the virus, inflammation is created, sepsis occurs, and cytokine and tissue factor release also occurs. This results in increasing thrombin levels in the circulation, so the patient becomes hypercoagulable, more likely to clot. The body's response to that is to accelerate the fibrinolytic system. And then there's a fight between clotting and fibrinolysis. And sometimes those patients wind up being hypercoagulable, normal coagulable, or in the extreme setting, and very serious one, where they develop what we call a consumptive coagulopathy. And that is that the rate of destruction of these clotting products is so great that the prothrombin times and the partial thromboplastin times get very long, and the patient can bleed and actually bleed to death. At the same time, while there's a clotting process going on. Very complicated disease, very difficult, especially in the later stages, to really affect with treatment. In addition to that study, another study I have just seen was a meta-analysis that was a very well done piece about recommendations for prevention and treatment of venous thromboembolism associated with the coronavirus. These authors emphasize the importance of a complete risk factor assessment for patients who are at moderate or high risk using one of the available scores, such as the PADU or a Caprini score. And of course, if they are moderate or high risk, they should have prophylaxis. Low molecular weight heparin was recommended for at least 7 to 10 days. As we know, that's the effective time required for efficacy for these drugs. But in addition to that, what's really more important is that the low molecular weight heparin should be continued until the risk factors are removed. In other words, treating the patient for the period of time that the patient's at risk. And this meant, in some cases, continuing prophylaxis following discharge, especially those with persistent risk factors, such as pneumonia, COPD, immobility, and the like. They also suggest that all severe coronavirus patients with pneumonia are at high risk and should receive anticoagulant prophylaxis unless there's a contraindication. Dehydration is another factor that was emphasized as a causative factor for developing venous thrombosis in these patients. Pregnant patients also need to be risk assessed, and prophylaxis recommended for those at risk during and following pregnancy, sometimes for 6 weeks or longer, postpartum, depending on the clinical situation. At all times, in all patients with this disease, a high degree of suspicion for venous thromboembolism should be done with screening at the drop of a hat for those that are suspected in any way of having a venous thrombosis, and certainly those that have abnormal clotting tests, particularly the D-dimer, which is a sensitive marker for thrombosis. Patients that develop DIC and consumptive coagulopathy, of course, require special treatment. Anticoagulation choices may have to be altered. It may have to be stopped. Antifibrinolytic drugs may need to be given. Mechanical methods are critical when these patients are in this stage of their disease. And the use of extracorporeal membrane oxygenation may be important in some cases. In conclusion of this study, the authors expressed that risk assessment and prevention of venous thromboembolism is particularly important in the overall comprehensive treatment of these patients with coronavirus. The condition of some patients is known to change rapidly, and the risk and outbreak of VTE during treatment is common, so that one has to be on top of these patients on a day-to-day and actually hour-to-hour period. There's a dynamic changes in blood risk, which should be dynamically assessed. For example, the D-dimer level goes up. You really should screen these patients for thrombosis, maybe adjust their anticoagulation, maybe increase it in some cases in order to reduce the incidence of VTE, which of course will factor into the eventual occurrence of fatalities. One of the best ways, in my opinion, to assess patients is with the Caprini score, because it represents a thorough history and physical with 40 elements. And we know as the number of risk factors goes up, the incidence of VTE goes up, and also each risk factor has a power or tendency to develop thrombosis. And so by combining the relative powers of each of those risk factors and the number results in a score. And there is a nonlinear or linear, in the case of a particular population, increase in the score based on their chance of developing a venous thromboembolism. Here we see a nonlinear increase in general surgical patients. I'll show you later a more linear increase in patients in the ICU. Many risk forms can be used. Here is one common risk form that we use to evaluate these patients. I'd like to now discuss a very important paper that was published by Andrea Obi and her associates at the University of Michigan in 2015. This was a retrospective cohort study of 4,844 patients in the ICU over a 5-year period. The overall incidence of venous thromboembolism was 11.5%, and significantly higher in those with a score of over 8, where the incidence was 11.5%. And as the scores went down, the relative rate of thrombosis went down as well. The presence of pneumonia and central venous catheterizations increased the VTE risk. They had a very powerful determinant nature for VTE. And here's the linear increase. And as you can see, as the VTE rate does go up as the score goes up. So it's a very good correlation. So in conclusion, the presence of coronavirus creates significant problems regarding thrombosis, prophylaxis, and treatment. Traditional anticoagulants prevent venous thromboembolism, including fatal events. Most fatal events are prevented with an adequate course of heparin or low molecular weight heparin. Thrombosis prophylaxis is indicated for most patients. The presence of disseminated intravascular coagulation in the most serious cases may increase the risk of bleeding if a consumptive process exists. Standard coagulation tests can predict death from the coronavirus, and the Caprini scores can identify those who are high risk for thrombosis and death. So what is the value of combining these measurements? First of all, you improve the identification of overall patient risks. You have a patient with a high score and they also get a high D-dimer, that patient needs to be screened immediately to make sure they're not already don't have a clot. Then the anticoagulant prophylaxis has to be refined, and it depends on a variety of circumstances. Sometimes you'll have to increase the dose. Sometimes you'll have to decrease the dose depending on the chance of bleeding, presence of renal insufficiency, which can occur as a result of sepsis, and so forth. And the problems associated with DIC are many, and the anticoagulation may need to be adjusted. Antifibrinolytics may be used. ECMO may be appropriate. There's a whole variety of circumstances that have to be carefully done according to the individual patient's characteristics. And finally, going forward, we need to explore the use of aspirin, factor XI inhibition, or E-selectin inhibition to provide appropriate thrombosis prophylaxis, since all of these methods have been shown to decrease bleeding rates compared to low molecular weight heparin. So I'd like to thank all of you for listening to this presentation and encouraging you all to visit my website for further information at venusdisease.com. And please, everybody, stay safe and have a great day. Thank you very much. Thank you very much. First of all, it's an incredible honor to be asked to give this lecture and to be able to interact with all of the physicians and people in China. This is a great pleasure for me, and I'm very indebted to the Chinese for their work in producing a number of different articles based on the Caprini score, and they have probed every specialty, and we now have have a common enemy, and it really is in two parts. The first part is to attack the #1 preventable cause of death after surgery, which is venous thromboembolism. If you give the right prophylaxis to the right people, almost very few people will die of the disease. The second problem is this very recent worldwide nightmare of the coronavirus. And already the Chinese have made incredible contributions to identifying the fact that not only is the score important for these patients, but it's incredibly important to go beyond the score. For example, knowing what the D-dimer, fibrinogen levels, prothrombin and partial thromboplastin times are, in addition to scoring the patient, is very helpful in predicting both preventative measures that need to be used and also mortality.
非常感谢非常荣幸来参加我们这次这个活动。然后他说呢，他今天主要想介绍一下这个 VTE 疾病。我们知道 VTE 疾病的话是一个非常常见的一个疾病，而且是一个非常常见的一个致死性的一个疾病，而它是可以预防的。那今天晚上主要介绍这方面。另一方面呢，他也说的话，我们中国的专家在这方面做了很多的工作，他也表示感谢。特别是最近我们在新冠病毒这个斗争的过程中呢，我们很多中国的专家呢也做了很多关于新冠病毒和 VTE 相关的一些研究，比方说这个新冠病毒病人的他的一个第二具体的变化呀，他的显微蛋白的变化呀，然后的话根据这个，然后的话进行一个很好的一个评分，根据评分情况来分级的进行预防。所以说他也看到了这方面的很多的一个中国专家的一些工作，在这他一并表示感谢。Please, Professor Caprini.
Thank you very much.
Yeah.
The next point that I'd like to emphasize is that this Caprini score is nothing more than a thorough history and physical, interrogating the patient to find out all of those factors which could influence the outcome of an operative procedure or dictate in certain cases where there are quality of life improvement procedures that perhaps the risk may be even too high. And I think it's very important to do this score. And by doing this, one is able to, what are the components? The components of the score are, number one, a thorough history and physical. And number two is counting the number of risk factors. And then the weights of each risk factor are also important. So for example, bed rest is not as in, by putting these together, one is able to come up with a simple number, and that number has been tested in over 5 million patients, and the number creates a linear or nonlinear association with the incidence of venous thromboembolism. So as the number goes up, the incidence of clots goes up.
那他提到了，我们知道的话，这个 Caprini 这个评分是吧？这是以这个教授的名字命名的。那么他说这个评分的话，第一个目的主要是要把这个病人做一个很好的一个分层，让我们识别哪一些病人是危险病人，是吧？哪一些病人是相对来说低危的病人，哪些是高危的病人，这个分层。另外一个的话，通过这个评分的话，你可以更加的简化你的这个把这个分层的话，这个难度给降低。这样的话，我们可以很容易的看出来，如果打分比较高的病人的话，那可能就属于高危的病人，他很容易得 VTE。比较低的打分的话，就是比较低的病人。所以说，通过这个分数的话，可以看出分数的权重，可以很好的对这个危险病人进行识别。而这一套系统呢，他刚才提到了，已经在500万的一个病人里面得到一个非常好的一个验证。
I would also like to emphasize the fact that the score is a dynamic instrument, and people need to be scored on admission, and then as the hospitalization occurs, things develop. Patients come up with, they leak from their anastomosis, they develop infection, they develop pneumonia. Cancer is all of a sudden discovered unexpectedly. These risks add to the initial risks, and so the instrument is ongoing, dynamic. And then when the patient is ready to go home, a final risk assessment is done in order to calculate whether or not the patient should go home and receive prophylaxis after discharge.
另外一个的话，这个评分它其实是一个动态的，它不是一个固定的。这个病人这个评分从病人一入院开始，他就开始有一个评分。然后入院之后的话，它随着病人的病情变化，这个评分可能也会发生变化。比方说，病人可能会得一些感染啊、肺炎啊，或者说的话，病人需要因为一些疾病需要卧床，或者说需要得肿瘤，或者说病人需要接受手术。那么这些都会使他的一个评分发生变化。那么根据不同的变化，这个评分的话，我们再来决定病人下一步的话是可以安全的出院呢，还是需要接受一些抗凝的治疗呢？
When looking at the slide set, there are 4 very important things to be understood, and that is the influence of anesthesia and the changes of anesthesia and how they affect the incidence of venous thromboembolism. A full anesthetic replicates all 3 factors of Virchow's triad: hypercoagulability, vessel damage, and stasis. The second important consideration that's in the slides is what is ambulation? And we know that walking 10 meters or 32 feet constitutes ambulation, not going to the bathroom. The third point is that we know that the administration of heparin or low molecular weight heparin to patients at risk lowers the fatal pulmonary embolism rate to a very small percentage, a fraction of 1%. And finally, it's very important that one understand that there are 2 elements in the calculation of the risk. The first element is the operative procedure, and the second element is the baggage, all of those risk factors that the patients bring to the operating room. The same thing when they get on an airplane. Airplanes don't cause blood clots. It's the baggage you put on an airplane on a patient that causes a blood clot. So these are very, very important. So we need to get away from classifying patients solely according to their type of procedure. And I must say that I'm a little disappointed in the American Society of Hematology and the influence of the West. They haven't seemed to come to grips with this final and very important point.
他想进一步提到的话，这个我们 特别需要关注的几个跟 VTE 相关的因素。第一个的话就是麻醉性的因素，是吧？我们知道一个麻醉的话，一个特别在接受全麻的病人的话，这病人是非常容易血液高凝的，因为这个时候的话，我们知道有一个 Virchow 这个血栓生成的 Virchow 3联因，而这个全麻的病人的话，这时候的话，这3个危险因素都具备的，所以是血栓的一个非常高危的一个情况。第二个的话，就是他提到了一个这个早期的活动，就病人的活动是非常重要的。如果病人的话术后的话活动的话，步行的话，如果少于10米，如果步行能力低于10米，仅仅的是一个去卫生间像这种情况都不算一个活动，他认为的话，如果活动的话比较少的话，或者活动能力比较差的话 ，ambulation 这种情况比较差的话，能力比较差的话，这也是一个比较高危的一个 VTE 的一个因素。另外一个的话，他提到了一个用这个低分子肝素的话，对这种高危的病人用低分子肝素可以大大的降低这个它的一个 PE 的一个发生，所以说的话，这个还是非常有效的。另外一个，他提到了一个这个绷带是吧？术后绷带的应用的话，这些话都可能会加重这个，因为制动可能会增加这个VTE 的一个风险。Okay.
Thank you. I would like to conclude by saying, first of all, there's a large number of articles on the score in China in almost every specialty, but that includes some articles that are negative about the score, that say the score isn't the total answer. And that's the thing that I am so excited about, because the score is not perfect. It has to be advanced. And nowhere is that more important than, as we talked about before, with this coronavirus problem, where one needs to know about the D-dimer, the fibrinogen levels, the platelet count, the prothrombin and partial thromboplastin times, in order to do a full assessment of both the extent of the disease and the mortality associated with the disease. So it's a great honor to be in the midst of all of these fabulous Chinese authorities and physicians, and I'm sure that together we will advance the state-of-the-art for these two problems, preventing a fatal pulmonary embolism and attacking the problems of the coronavirus together. And so thank you very much. I look forward to learning a great deal from all of you today.
那最后的话，这个 Caprini 教授总结了一下的话，他说他这个评分的话，其实还是有很多争议的。我们能看到现在有很多的文章也对这个评分提出了质疑，但他觉得这样是一个好事情。他说的话，没有一个评分制度是完美的，大家提出了很多的意见，更说明这个评分系统的话，它是一个动态的，还需要更多的一个完善。所以呢，他在这儿也希望我们那个中国的一些同行能做更多这方面的一个研究，然后的话跟他一起，我们一块儿来把这个评分系统更好的完善，也更好的去跟这个 VTE 这个疾病做斗争，更好的去跟这个新冠病毒做斗争。最后他希望大家都能够取得一个胜利。